Excellent. Well, welcome to the Advanced Center conversation with Natalie Bellini. Natalie is endocrine, or Dr. Bellini is an endocrine nurse practitioner and program director of technology of the Diabetes and Metabolic Center at University Hospitals and faculty advisor for Close Concerns. Dr. Bellini's research focuses on diabetes management, including the use of GLP-1 agonists in patients with type 1 diabetes. In addition to her work as a practitioner and faculty member, she also co-hosts a podcast, Diabetes Dialogues, Technology, Therapeutics, and Real-World Perspectives, with her colleague, Dr. Diana Isaacs, a PharmD. So welcome, Dr. Bellini, and I'll start us off with your expertise in staging and treatment for diabetes care.
Thank you, everyone. So my name is Natalie Bellini, and I'm actually here at my office in Mayfield Heights today, and I am a clinician that sees patients 3 to 4 days a week. I do some research. I do some work with the American Diabetes Association, as well as the Breakthrough Type 1 Diabetes for university hospitals. So let's talk about type 1 diabetes. We as clinicians think about it as you didn't have it and then you had it, and there was not really any kind of in between. And now we know so much more about it. So back in 2015, the American Diabetes Association published an article about the staging and screening of type 1 diabetes. And most of us read it and said, that's really interesting. It doesn't change my clinical practice today, and put it aside. But truly, that first article was based on an NIH-funded study called TrialNet. And before that, another trial called the DPT-1 trial, Diabetes Prevention Trial, looking at how does type 1 happen? What happens with it? And ultimately, what we learned is that someone develops the autoantibodies, and there are 4 that we can measure for type 1 diabetes, sometimes years before they actually get the disease. And those antibodies start to attack the beta cells in the pancreas, and eventually that person has enough destruction of the beta cells that they need insulin. Why does that matter now? It matters because we now recognize that if someone is caught early, we find those antibodies, 2 of the 4 positive, there is 100% lifetime risk of developing type 1 diabetes, 100%. So if we know it's coming, we can present at a different place than if we don't, which is we can reduce that risk of DKA from about 60 to 65% at diagnosis down to about 6% at diagnosis. So we're reducing that risk of hospitalization of DKA, and that person's outcome forever is different if we can catch it early. The second benefit of knowing that this type 1 diabetes is coming, besides that soft landing with diagnosis, is there are now medications that we can use to delay the onset of type 1. And we were the first in Northeast Ohio to infuse that medication. It's a CD3 monoclonal antibody. And we were the first in Northeast Ohio to infuse a person to prevent that onset of type 1 diabetes.
Wow, that's very interesting. And nice to hear that UH is a lead in this area of research. Yeah. And so do you want to share a little bit of information or experiences that you have on your podcast? I was very curious about it. What kinds of topics do you have on it? When is it? How can we reach it?
So Diana Isaacs is actually a pharmacist at the Cleveland Clinic, and she and I have collaborated on lots of things. We've written papers together. And she called me one day and said, would you like to do a podcast? Sure, I'll do a podcast. And I didn't realize that I was going to be videotaped. So I think I said yes because I thought I was only going to be speaking. And now we do one almost every single week. And we do them through HCP Live, which is a medical audio-visual journal online. And you can find our podcast. It's called Diabetes Dialogue Technology Therapeutics, and it is available on all podcasting. So we actually talk about things like, okay, there was a paper. One of the things that's happened recently is we're starting to use medications called GLP-1s, right? Glucagon-like peptide 1s in people with type 1 diabetes. They're not FDA approved specifically for people with type 1, but they are approved for people with overweight and obesity. And when we think about people with type 1, if you close your eyes and look at your textbook, what do you see? You see a 12-year-old, right? That's very, very thin, that was, lost a bunch of weight and presented in DKA. And then you, as a pediatrician, might say followed by endocrinology. And what we now know is that 60% of the people with type 1 diabetes actually have a co-diagnosis of either overweight or obese. So that's, first of all, we're misdiagnosing because we don't see it. We also realize that 60% of the people that get type 1 diabetes are above the age of 20. So the diagnosis has completely changed and that trajectory has completely changed. And we're missing people with type 1 as adults because we always think about it as that little skinny child that is in your textbook. And then we see, what do we see as type 2? This sort of rotund built circle with gray hair on top. And that's your picture of your person with type 2. And that really isn't what we see in endocrine clinic every day.
Very interesting. I think such as a case study, like a 31-year-old woman with obesity with a BMI of 34, she may present with fatigue and polyuria, polydipsia, with elevated plasma glucose, like 270 milligrams, and then a point of care testing hemoglobin A1C of 11. So how would you address somebody like that in the clinic?
So, first thing we need to do a couple of things all at the same time, right? First of all, when we see people, we are using antibody testing pretty much across the board. If we don't know for sure anymore, we really are ordering the antibodies. And you can order them through Epic, and it's not a difficult thing to do. There are 4 that we order. And so we look to make sure we know what we're dealing with, right? Because even though, and a C-peptide, so those are the big 5 things that we do. We want to know, is this person still able to make any insulin at all? Because C-peptide is that marker of residual insulin production, endogenous insulin production. So that's the first thing. And then we want to know, does this person have antibodies? Because if they do, their trajectory is going to be different. They will eventually need insulin. We might not need insulin right away. If they're still making insulin, we might use a GLP-1, like semaglutide or tirzepatide. If they're not making any more insulin or their insulin production is already less than that normal range, we are going to start insulin earlier and realize that and do a different level of education around that, how quickly they may convert to needing full insulin dosing. But we're going to manage it just like we do any other person with diabetes. Once we know, do they have type 1 or type 2? What is their cardiovascular risk? So family history, most of us, we kind of, what happened with your parents? What happened with your brothers and sisters? It's really important in diabetes because the American Diabetes Association has changed their standards of treatment. And I'm actually on the standards of care committee this year, and we're looking at, don't look at just the number. Don't look at just the A1C. If they're at high risk for kidney disease, we need to be using an SGLT2 inhibitor, for example, empagliflozin or dapagliflozin. If they have a high cardiovascular risk, if mom died young of a heart attack, if their brothers already had one, if they've already had, then we need to be using a GLP-1 sooner, regardless of their A1C. So in the past, what we did was we did this delay to treat. We'd start with metformin. We'd threaten the person. We would tell them if they didn't behave, they were going to need insulin one day. And then we'd wait until the A1C climbed. And then when the A1C climbed, we'd add another medication. And then when the A1C climbed after that medication failure, we'd add another medication. And instead, we've completely changed the outlook and said, let's do this completely differently. Let's actually look at their risk and look at the medications that we can now use that have proven reduction in cardiovascular, stroke, and kidney risk. And so we are adding, we don't just start with metformin anymore, ever. We don't recommend that. We want to look at those risks and say, and what about obesity, right? We need to treat that immediately. So what we're doing is we're saying, let's add metformin with a GLP-1 at diagnosis or with SGLT2 inhibitor if they happen to have hypertension or protein in their urine already and signs of kidney disease. So we've completely changed what we do with the person in front of us based on their other health risks.
Very interesting. I know that we have so many participants on the call this morning, so thanks to all for coming on so early on a Friday morning. And I'd like to open it up for questions. And if you would like to just unmute, feel free. And I see Dr. Rao's on the call also.
Yeah, thank you, Mary. Thanks for pinch hitting. I just wrapped up at 7:33, so we're just ready to sign on. Thank you, Natalie, for joining us this morning and discussing your very interesting work. We're privileged to have you. I think that, yeah, as you mentioned, the diagnosis of type 1 versus type 2 has changed dramatically. I was a director of a pediatric obesity center within a division of endocrinology, and I know we used to see type 2 in children, and that was a big deal. Now we're talking about something quite different. I wanted to ask you about your experience or your division's experience with latent autoimmune diabetes in adults. In other words, somebody who presents like the woman that Mary had just described, and yet the C-peptide is actually, present in significant numbers. Antibodies may or may not be present. GAD65 may or may not be present, and you're not quite sure. My approach has always been to just kind of treat them as a type 2 and then monitor whether they're making insulin or not, because 6 months from now they may not be. Is that a phenomenon that you're seeing quite often?
We see it a lot. So the
Mhm.
difference between type 1 in children and type 1 in adults, or latent onset diabetes of adults, is very different. It's a different progression, right? Kids flip.
Mhm.
They end up converting to type 1 very quickly. Where LADA, this latent onset diabetes of adults, if they're antibody positive, we have to start with one day you're very well going to need insulin. But they're very interesting cases because they end up on, 5 units of basal insulin, 8 units of basal insulin, not weight-based dosing, right? So if they're still making insulin, we love it if we can use a little bit of GLP-1 to help reduce that cardiovascular risk, a little bit of other things. Um, we shy away from SGLT2 inhibitors with type 1 diabetes in general because of that increased risk of euglycemic DKA. So, but we will use other medications, but we do start with they tend to need smaller doses. Weight-based dosing doesn't work with them, but they really do need some insulin, and they really do need to be told that eventually, if they're antibody positive, that they may need all the insulin that, they may end up on full-blown insulin dosing. But we see it a lot, right? If 60% of people are getting diagnosed as adults, we see a lot of adults getting diagnosed with this
Wow.
slower progressing type 1, which
Yeah.
is that LADA, and the
Mhm.
beautiful thing right now, although it's argued back and forth at the American Diabetes Association level, is, we can call it LADA treated as type 2 and get medications for type 2 diabetes, like semaglutide or
Mhm. Mhm.
tirzepatide. And then we can argue it as LADA treated as type 1 and get them an insulin pump or whatever else we need when they're ready for that.
Right. The other question I had for you is that just based on my experience in the pediatric end, and I think it's pretty sound advice. So you have an adolescent or perhaps a young adult who is ill. In other words, they are dehydrated, polydipsia, fatigue, maybe some weight loss as well. We always teach residents, hydrate them, give them insulin, and then don't worry about the diagnosis type 1 and type 2 a little bit later on. Is that the approach that you guys are taking?
We would love if their antibodies were drawn right then, because the
Yeah.
antibody is positive right then. It doesn't wait till they're clear. So if you get us, because you might do something very different. You might send them to primary care and then they get lost, right? If you know they're antibody positive, we want them. We actually keep slots open in our schedule for people newly diagnosed with type 1 diabetes. We had someone the other day that was went to the ER and they were antibody positive and they were told to follow up Monday. And that's not okay. Monday isn't going to work for that person. I need to know. And we quickly did a video visit and treated that patient and he's been fine. So we will work those people in because it's critical that they do get insulin right away. So it's easy to draw them. There's only 4 of them. We can help you learn to put them in the chart and take care of it. And you can send us a consult. We have a team that's inpatient that will help. We have a diabetes team, but we also want to get them into the outpatient center as quickly as possible so that they don't end up returning in DKA because they didn't understand how to dose insulin, what to do. Those people have to learn how to count carbohydrates or at least estimate them. There's a lot. It's a big diagnosis needing insulin all the time. So we would rather you draw them, even if you're not going to be able to get them to us, right? Get me a message through my chart and we will take care of it from here. We have a whole team that is willing to help. It's not just Natalie. There's other NPs. Our fearless leader, Dr. Hedy Poglu, has said, Natalie, do what you need to do, make this work for our patients, keep them safe and healthy.
Thank you. And speaking of Dr. Hadipoglu, Batul, you have a comment or question? Thank you for joining.
Yeah, thank you for having us. And I'm so glad that we have Natalie and her amazing expertise. And Natalie, for the audience, would you agree that in adults, we also see the presentation of very rapid type 1 diagnosis like it happens in childhood, and then there is LADA. So I want to make sure the audience recognizes that the presentation of type 1 can be still very abrupt, and with DKA even at age, our oldest is I think 84 years old. That is a new onset, abrupt onset type 1. I just want to make sure the audience understands this. If you want to comment on that.
Absolutely. So we recently had someone 84 years old who said to me, I'm the head of the hiking club. I've done everything right. All my friends have diabetes. This isn't fair. This isn't fair. Yeah, you've had autoimmune, you've had these antibodies in your blood for maybe years, right? So we don't know why all of a sudden that antibody response happened and your pancreas finally decided to not make any more beta cells, but you're 85. Now, the beauty of that is what? I can relax the goals. I'm not preventing heart disease because we don't have that same trajectory, right? Her life different than someone who presents at 25 with type 1, but we also have those very rapid onset newly diagnosed people with type 1 diabetes where they were fine, they lost weight, 3 weeks later their blood sugar their glucose is 900 in the ER. Absolutely.
And Natalie or Batul, could you comment, because this is something I've witnessed as well, is people using hemoglobin A1C even when they suspect type 1 diabetes in adults. And my understanding is that because of relatively acute changes, which Dr. Hadapoglu was indicating can happen, it's not terribly helpful. And I can see it being very detrimental if it's normal or just mildly elevated and kind of dismissing the diabetes to an extent that's not warranted at all. Is that something that you would discourage?
Absolutely. It's part of the decision, right? We want to know where they present it, right? Where they start. But if it happens very rapidly, we might have an A1C of 7.5 or 8, but full-blown DKA, right? So their blood sugar can be very, very high, very, very quickly. So we need a glucose, we need antibodies, we need, obviously if they're we need to treat the DKA if they have DKA, but we really are basing our clinical decisions now on antibody testing for type 1 versus just you were a child, you must have type 1. Just like you said, Dr. Rao, there's a lot of people now developing type 2 as children, right? So these diseases are becoming this mix, right? 60% of people have overweight or obese in the United States. It's interesting, 60% of people with type 1 have overweight or obese. So we can't look at someone and decide. We must do the antibody testing. And speaking of antibody testing, the American Diabetes Association now recommends all first-degree relatives of people with type 1 get tested for antibodies because there's a 15-fold increased risk of having a type 1 diabetes in your family if you have someone else in your family with type 1. So that is where the screening for type 1 happens. We are part of TrialNet at University Hospital, so someone can get screened for free if they have a first-degree relative. But anyone with celiac disease, anyone with autoimmune thyroid disease, and anyone with a first-degree relative of a person with type 1 diabetes are all encouraged now with the ADA guidelines to screen for type 1 diabetes because we can delay the onset, because we can look at the trajectory differently, because we can stop the DKA.
Thank you. And any additional questions or comments?
I have a question for you. And it seems we're making such great strides in diagnosis and treatment, and seems there's a lot of self-management on the patient's end. And I noted one of your colleagues had to sign off and stated that you're a leader in helping to transfer this information to patients. Any guidance for providers on assisting patients with self-management?
Self-management with diabetes is not easy, right? This is a disease that someone sees somebody for, 0.6% of their year. And the rest of the time they are out there trying to do it on their own, right? It is very difficult. So what we do at the Diabetes Center here is we have educators, we have pharmacists, we have dietitians, we have nurse practitioners, PAs, we have Dr. Hedy Poglu, who is leading this research pack of us, helping these people, support them in between visits, right? And that to me is everything, that the person can connect with other people, that okay, I'm struggling with eating out. Okay, come and see our dietitian, or help us do it this way. Let's meet other people. We actually offer a very interesting program where we do what we call diabetes retreats. And it's a half-day program. And we actually have one in November on National Diabetes Day for people with type 1 diabetes, specifically geared towards people with type 1 to learn about new technology, meet other people. Those are the kind of supports that really make a difference. And that's what studies show. The data shows the more interactive the person is and the more support they have, the better they do long term.
Great advice. Also, I know that we often acknowledge that the diagnosis is a team sport, that many professionals contribute to this, and so does the patient. So it seems we need to do some type of education or raising awareness of some of those risk factors that you identified that people could be screened for and then gotten into the sort of healthcare system earlier on. Any thoughts on that?
So we are working on this right now with our PEDS colleagues because the idea of screening is really scary for a primary care or a pediatrician when you don't know what to do with the data. And that is really difficult, right? So because when you screen for breast cancer, you order a mammogram, they go to get the mammogram, and whether it's negative or positive, the primary care is really out of that trajectory, right? They are completely out of what happens next. They support the person if they have breast cancer, but they really don't they don't do that other side, right? It's the same with a colonoscopy. When you screen for type 1, you need to realize that we are here. The diabetes center is here. And if you message us through my chart, we will take care of the person. If they are antibody positive, our goal, our job at UH is to complete that, whether they're 15 years old and they're a sibling of someone with type 1 diabetes, or whether they walked in and said, wait, my sister wants me to be screened, and you don't want to do it because you don't order labs that you don't know what to do with. This is the perfect example of no, you do, because we'll take care of them. Whether they have 1 out of 4 or 4 out of 4 antibodies, we will help you decide what to do next and make sure we manage them for you.
Great, thank you.
Thank you, Natalie. We just had a question about the retreat, and we're going to share information, so we don't need to address that here. Any additional questions or comments?
I was just curious what your role is in faculty advisor to Close Concerns.
So Close Concerns is an online organization that actually, you'll love this. They hire students they spend their 2 years with us. And what the students, they're pre-med students. So they spend 2 years covering the business as well as the medical side of diabetes. And interestingly, they all come and live with me for a week and spend time in observation hours through university hospitals. They apply and do, and they call it Camp Natalie. They love my husband. They live and work with us. They get to spend time in PEDS. They do some inpatient and they do observation in diabetes and look at not only just how does a glucose sensor make money, or how do you use what happens when you actually prescribe a drug, but also then how do we communicate with patients? So it's a company that's actually based out of California, and the head of the company happens to have type 1 diabetes. I met her at a conference and she said, oh, would you be willing to help with this? Yes.
Neat.
So one more thing we should mention is the use of these other drugs with type 1 diabetes. And I think that Dr. Rao had mentioned this yesterday and I had forgotten, so we'll close on this. So the use of something like a GLP-1, what do we know about, like semaglutide and tirzepatide? We know they reduce cardiovascular risk, right? We talked about that. When we reduce cardiovascular risk, it's all in obese, overweight, and people with type 2 diabetes. But we also know that people with type 1 have the same risks, don't they? They have an increase, they die of heart attacks and strokes at a much higher rate than people without diabetes. So what do? it's a very difficult thing because getting coverage can sometimes be a little bit sticky. But we are using GLP-1s in people with type 1 diabetes all the time now because we believe in it. There are some initial now first one randomized control trial out of the University of Indiana with a colleague of mine, Viral Shah. He has started a tirzepatide in type 1 study. So we are looking at how do we get this FDA approved for people with type 1 so that we can get insurance to cover it? But the drug, if you think about a GLP-1, whether it is tirzepatide or semaglutide, what does it do? It slows down that gut digestion. It stimulates the brain, it shuts down that food noise, right? It says satiety is a messaging, right? It shuts down that extra glucagon production from the liver, and it tells the pancreas to make insulin when the glucoses are high. So what the drug does for someone with type 1 is all those things, but the insulin production. So we see huge benefits. We see weight loss, we see a reduction in insulin needs, and we see less fluctuation in glucose. So we are using them as often as we can get them covered for people with type 1 diabetes in our clinic all the time. And the people that use the medications love them, but also the people that we see it as protecting their hearts and their kidneys and their risk of stroke. So it's a very exciting time in type 1. We have not had this amount of possibility ever. I mean, really ever.
All right. Thank you so much. I'm just going to give anyone one last moment to ask any questions or make any comments. Okay, thank you so much, Natalie, for joining us this morning. It was a delightful discussion, raising a lot of awareness, and I have to go and treat type 2 diabetes and obesity now, so I'm going to get started. Everyone have a wonderful day. Thank you.
Thank you,
Thank
Natalie.
you.